Okay, finally, for part 2 of respiratory, let's see what we're going to talk about. So before we get started, let's remember where we left off on our last test. We talked about croup. So now we're going to go into epiglottitis. Before we talk about epiglottitis, I want to point out something anatomically. Make sure that you are familiar with, kind of understand what we're talking about here. So you've got your oropharynx and nasopharynx, hypopharynx. As you go down, remember how we talked about when a patient is intubated, how your trachea is in the front, so your airway is in the front, and your esophagus is in the back, okay? So here's your airway. Voice box is in this area, your larynx is here, and your trachea. Where is your epiglottis? So if you look here, our, oh, that made my highlighting go away. This area right here. What if I highlighted it? Let's see. Right here. That's our epiglottis. When we talk about our next disease process, epiglottitis, this is the area that is affected. And you can imagine if you have swelling here and you have your opening to your trachea here, that can become a major problem. When you have croup, you also have narrowing of this tissue in this general area, but it's usually not to the extent that epiglottitis can be. So let's go to the next slide. When we talk about epiglottitis, did I skip one? No. When we talk about epiglottitis, there are certain facts that we want to be aware of. Keep in mind, this is comparing epiglottitis to croup because the symptoms can be similar in some aspects. So croup was caused by a viral illness in most cases, not all the time, but most of the time, that virus being parainfluenza. Now, when we talk about epiglottitis, we're going to say that a common cause of epiglottitis is Haemophilus influenza type B. The fact that I spelled Haemophilus influenza with italics, or it's italicized, is a clue from our micro class. Hopefully we remember that that is a bacteria, and that's why it's italicized. Haemophilus influenza type B has nothing to do with the flu, okay? It's a bacteria. It is, when we get the DTaP Hib vaccine 5 times before we start kindergarten, that's what we're being protected against. Now, epiglottitis can also be caused by strep or staph. There are other things, just like there are other viruses that can cause croup. Hib is just one of those that tended to be more prominent as a cause. But because it can be caused by things other than Hib, we will start this patient on antibiotics that cover gram positives as well as gram negatives, Hib being a gram negative. So this patient will be on a cephalosporin to cover our gram negatives, and will also be on clafurin or some other things that could possibly cover our gram positives until we get culture results and sensitivities back. We can narrow down exactly what they're infected with. Something else we know about epiglottitis is that it tends to affect children of preschool to school age years, 3 to 7, as far as the age range goes. Compare that to croup, and we said toddlers to preschool age range. If you go back and look at your notes on croup, it tended to be the younger kids. Here we go, Lord, I start talking and I start yawning. We talked about that today. Okay, so epiglottitis tends to affect a little bit older child than croup did. There are three things that we look at, the three Ds as far as the symptoms: dysphagia, drooling, and distress. Dysphagia meaning they can't swallow or they have difficulty swallowing. Because they can't swallow, they drool. They can swallow, they don't want to swallow because of the pain and the distress due to the pain, the severe sore throat. With croup, we said we normally have a mild fever. With epiglottitis being a bacterial infection, we tend to see a high fever, and that helps us distinguish um, epiglottitis from croup. Another thing that distinguishes it is that epiglottitis tends to be a very sudden onset, and it can progress very rapidly. When I say progress, meaning it can cause complete obstruction of the airway very rapidly. And it is considered life-threatening, whereas croup is considered a self-limiting illness. It usually resolves over time. So epiglottitis, if you're a cartoon person or a meme, whatever you call this thing, if air raid helps you, then here you go. Airway closed, increased pulse, restlessness. Yeah, that makes sense. They can't breathe. Eyes bugging out of the head. They don't know what's happening. They feel terrible. They're running a high fever. And this just hit. They were fine when they woke up, but now they're not fine. RAID, that stands for retractions. Now, let me pause there. What type of retractions do you think you would see with this type of illness? What kind of retractions are caused or result from upper airway obstruction? So maybe you would have supraclavicular retractions, suprasternal retractions, just throwing that out there. Retractions, anxiety increased, inspiratory stridor. Yeah, I've got to get this done. Inspiratory stridor. So when they are trying to inhale, they have the stridor and drooling. So the treatment here is whatever it takes to decrease their anxiety. We are not going to examine the throat, never stick anything in their mouth, and position them for comfort, which is the exact same treatment we did for a kid with croup or with croup-like symptoms at the beginning. If we have a child with stridor, we assume we have upper airway swelling, and you don't know the cause for sure of that upper airway swelling. So until you get them to a safe location, and safe means a sterile environment with a physician that is capable of intubating and or performing an emergency tracheostomy, you don't know. Are we dealing with a bad case of croup, or are we dealing with epiglottitis? You're gathering data and gathering clues that suggest one or the other, such as the onset, the rate of onset, the temperature, and things like that. So you can have an opinion, but we don't know for sure. So the treatment is the same. Keep them calm, keep from sending them over the edge to where their airway completely swells shut. This kid is very anxious and frightened. They are irritable. They've got that fever. So on the same hand, they may be lethargic. Um, but regardless, they're most likely going to prefer the tripod position. Like any child in respiratory distress that feels like they can't get air and they're air hungry, do not make them lay down. Don't make them lay flat on their back. Position them for comfort. And please read on page 1045 the types of retractions specifically and the symptoms that can be seen with epiglottitis. So you need to take this section that we're talking about in the PowerPoint to your textbook and correlate the things that I'm saying with what's in your reading and add to what I'm saying with what you find in your textbook. You're responsible for all of it. everything that has to do with epiglottitis and anything else we talk about in your book. And your book also, instead of the 3 Ds, they refer to the 4 Ds. Drooling, dysphagia, and distress we already mentioned, but they also add dysphonia, meaning the talking. They're not going to talk. They don't want to talk because it hurts. So look at this picture here. We have a patient that needed to be intubated, and the doctor was able to go down with a camera and visualize the epiglottis. And you may not know what to compare that to, but the epiglottis should not be so swollen that you cannot, that it's in the way, period. You know, this is where you would be trying to pass a breathing tube down, and you can see how the swelling could definitely impede your ability to, or the physician's ability to intubate this child, and they would need possibly a tracheostomy. So this was a post-intubation image in a child with acute epiglottitis. Note the cherry red epiglottis. Now, interestingly, this is a picture from 2008, and the child had been completely immunized. Okay, they got all their DTaP Hib vaccines, and they still grew Hib from the culture. So the vaccinations overall have greatly diminished the cases of epiglottitis compared to how it used to be. We rarely see it anymore, but you still have to have that index of suspicion because it can still happen and it can be deadly. So we can't write it off. The best way to diagnose epiglottitis versus croup is by visualization, such as in this camera view here. But if you're going to do that, you have to make sure, you know, if anyone's going to look down there, you better make sure that you're prepared to intubate or put in a trach, doing that sort of thing. Even starting your IV, if possible, needs to wait until after this airway is secured. The child crying from an IV stick could push them over the edge where intubation is not possible anymore, and we have no choice but to trach them. Being a bacterial infection, our white count tends to be elevated. So the great thing about bacterial infections is that we have the ability to treat them with antibiotics and resolve the illness fairly quickly compared to viral illnesses where we just have to ride it out over 7 to 10 days. So if we get them on the right antibiotics, typically, you know, it's a cephalosporin to cover the gram-negative Hib, then within a day or two, 48 hours, you know, they go from being in the ICU, knocking on death's door, to 48 hours later, they're extubated and they're way better because we got those antibiotics on board. And this story I found very interesting. So you have a cartoon here, and little Johnny was babysitting his little sister, and he's just cruising along, having a good time, watching his TV shows, eating a sandwich, drinking some milk, and parents come home and he's like, yeah, she's been real quiet, hadn't heard a peep out of her. And you can see behind him that the little girl is, you know, dying back there, gasping for air. And the brother hasn't noticed. So this is what happened. This gentleman says, my wife and I were out for lunch and we came home early after changing our minds about going shopping. I asked our son where our 10-year-old daughter was, and he replied that she was sitting in the rec room quietly. I went down to see her and found her sitting slightly bent over and drooling. She indicated a sore throat. I had just seen 2 cases of epiglottitis, so we took her to the emergency room where the diagnosis was confirmed and followed by a tracheostomy. Thank God we didn't go shopping. And that was in Canada. So the guy was a physician and he knew they had had some cases of epiglottitis recently. So He walked in and saw the girl who had been fine when they left, pointing at her throat, indicating that it hurt really bad and she's drooling. She's 10 years old. What else could it be? She's not choking, but her throat is literally swelling shut and very, very painful. She can't swallow, it's drooling. And sure enough, and she had to get a trach. And remember that trachs can be reversed, but they can be life-saving in the immediate situation. So in this image, we have an epiglottis. The top picture is an epiglottis post-mortem from a child that had epiglottitis. And the bottom epiglottis is post-mortem in a normal, a child that did not die from epiglottitis, and they had a normal sized epiglottis. So just look, what is that? More than double, probably 3 times the size of a normal epiglottis. And you can see, oh my gosh, when it was beet red and inflamed, the pain of that and the airway obstruction. There's no room for anything to get past that. So that's what we're dealing with. That's why we get our vaccinations. But if you've never had a child die from epiglottitis or hip meningitis, then you don't appreciate vaccinations because we are spoiled. We are too stupid as a society sometimes, and we take things for granted because our children didn't die from epiglottitis or mumps or measles or whatever else it is, because we're just dumb, dumb, dumb. Anyway, that's a whole nother lesson, isn't it? So nursing management of epiglottitis. Don't mess with the throat. Don't try to look at it. Do not leave the child unattended. So what if mom says, I need to go down the hall and call my husband, and you have more than one patient and you can't stand there with the kid for whatever reason, although you should. Um, are you going to let mom leave the kid? No, that's no, no, no. You need to have the child in such a place where that's not going to happen. They're not going to be unattended. Do not make them lay down flat. Put them on 100% non-rebreather in the least invasive way possible. So that does not mean strap a mask to their face. That would cause anxiety in the child. You could have the mother or father hold the oxygen in front of their face. You can deliver it by blow-by, whatever. You can put it in through the end of a styrofoam cup, whatever is the least invasive way that you can supplemental oxygen to them. Have that trach tray at the bedside. Have intubation equipment at the bedside and ready to go in a moment's notice. The hope is that the physician can get in there and make a diagnosis and make that decision of whether or not we need to intubate to secure the airway while we can before it gets any worse. And sometimes they will choose to take the child to the operating room to attempt the intubation in case it goes south. It didn't work out. Their airway was, too swollen, or it went ahead and basically totally occluded during the intubation attempt. They're in a sterile setting and they can go ahead and do a trach in that setting if needed. But the hope is that we can still intubate them and avoid the trach, and then we do the antibiotics in the ICU setting and they recover. From a nursing standpoint, before the decision has been made, you are monitoring this child for decreased effort suddenly. Maybe they're exhausted. Who knows how long they've been fighting this battle? You're keeping them calm and quiet. You're monitoring temperatures, axillary or tympanic mode only. Nothing goes in the mouth. Keeping them in their parent's lap or position of comfort. Remember, this is your 3 to 7-year-old range. And controlling parental anxiety. Don't forget that children will feed off of the parent's anxiety, and the only person that can calm that parent down is you. You have to be in control, in charge of the situation. That oxygen in front of the kid's face, that's something that the parent can hold and feel like they're helping. If you have to give Tylenol, you're certainly not going to be able to do that orally. We do have, IV options now if they have an IV, but if not, There's always the rectal option. Eventually, they are going to need IV fluids. And of course, they're NPO because, until we get beyond what's going on right now. So let's look at croup versus epiglottitis. Croup kids, when you put them on the sick scale, sick or not sick, compared to epiglottitis, croup kids look good. Epiglottitis kids look toxic. I talked to someone in my clinical group about what it means when a doctor's note says, like their progress note says, non-toxic appearing, or their appearance is non-toxic. And I asked the student, what the heck does that mean? Toxic versus non-toxic, think septic, bacteremic, think they look like they should, they're crashing. They need to go in the ICU. They don't look well at all. They're not really conscious. Their perfusion is poor. Their systems, some of their main systems are starting to fail them. They do not look well. Versus the child that looks uncomfortable. They're obviously sick. They're in some pain, but pulses are good, perfusion is good, vital signs are good. They're very conscious and alert. They're screaming and crying. That child versus that other child that really looks bad. I know there's a better way to explain that, but when a doctor's note says non-toxic, that means, yeah, they're sick, but they're all right for right now. A lot of times you can compare those two simply. Toxic equals bacterial. I mean, non-toxic typically is viral. I mean, that's just a blanket statement, but so the child with epiglottitis looks toxic. They look unwell versus the kid with the croup that does not. Epiglottitis is an abrupt onset, whereas croup is more of that viral prodrome. You start with the itchy throat, the next day the runny nose, the next day the throat's hurting worse. It drags on and you have days and days of it. The fever, we talked about the high fever versus moderate. Stridor, now with croup, it can just be a little, it can just be certain times a day, or it can be pretty bad. It's, bad enough that it causes significant retractions that gets them to the ER. You've got that range, but with epiglottitis, it's moderate to severe. There is no mild stridor with epiglottitis. Cough. Kids with croup have that seal-like barking cough. Kids with epiglottitis do not cough. It hurts too bad to even swallow, to speak, much less to cough. So speech with croup, they've got that hoarse voice, whereas epiglottitis, they don't talk. Epiglottitis kids can't swallow, and so they're drooling. Croup kids don't drool. So an easy thing to remember is, or one way to think of it is, kids with epiglottitis don't cough. Kids with croup don't drool. Kids with croup don't drool. Kids with epiglottitis don't cough. All right, so in this slide, we're comparing croup versus epiglottitis, and then we're going to bring in another disease process, which is RSV bronchiolitis. Okay, as a reminder, we had, let me get my laser pointer back here. We had, on an earlier slide, on the last exam, when we talked about croup, we talked about croup occurring in kids younger than 3. With epiglottitis, we said 3 to 7. This chart says 2 to 6. Big deal. We're not going to stress out about that, right? You get the point. Croup is in the little toddlers. Epiglottitis is your pre-toddler through, kindergartner age range, typically first grade-ish. And you don't have to memorize the male-female stuff. All of this stuff we have already talked about, but it might word it in a different way and point out some other things for you to review. Now we're about talk about RSV bronchiolitis. And as we go through the bronchiolitis slides, I encourage you to come back and look at this slide again, and things will mean more to you. Croup was viral, epiglottitis was bacterial, RSV is viral. The viral, gradual. Viral over here, gradual as far as the onset. Fever, low grade, fever, low grade. But something different about RSV, they have apnea and tachypnea here. Also, retractions should go there as well. And then we have wheezes that we hear a lot with our RSV, and our SATs tend to drop with RSV. So I don't want you to memorize this chart. I want things to make sense and fall into place after you've listened to this PowerPoint, you've reviewed your book, you've watched the videos, and then you come back and you review everything again. It ought to start making sense where you just, you get it. Okay. So bronchiolitis is not always RSV. Bronchiolitis is like saying someone has pneumonia, okay? Pneumonia can be viral or bacterial or fungal. It can be caused by many different things. Bronchiolitis is an itis of the bronchioles. The cause can be from many different things. Typically, in our little ones that are in the hospital with bronchiolitis, we find that the cause in the majority of the cases is RSV, but it does not always have to be RSV. So please be aware that bronchiolitis can be caused by something else. Bronchiolitis can be a broad diagnosis until a causative agent is discovered, if one at all is identified. Sometimes they will be admitted with just the term bronchiolitis. Sometimes they will be admitted with RSV bronchiolitis if they've already had a positive RSV test and we know they have symptoms of bronchiolitis. Bronchiolitis by itself is the most common lower respiratory tract infection in infants. So this is down in our bronchioles. Your bronchioles get irritated, they get inflamed, they get full of mucus, they constrict from the inflammation. The more swelling that occurs, the more inflammation that happens, the more fluid is produced, and you have a lot of wheezing and things like that due to that constriction. The most common etiology is RSV, respiratory syncytial virus, and that will be spelled out for you on the next slide. But it could also be caused from mycoplasma, parainfluenza, human metapneumovirus, some of the adenoviruses. Other things can cause bronchiolitis, okay? But frequently it is caused by RSV. We are about to enter RSV season, November to March. And, you know, they say that of the kids that get put in the hospital, most of them are less than 2, and 75%. And according to this statistic, of the cases caused by RSV are less than 2. The peak incidence is a child that's around 6 months of age. The younger they are, typically the worse they do, especially if they have a history of prematurity or chronic lung disease or some other comorbid factor. We think that breastfeeding does offer an advantage. If they contract RSV, they tend to do better if they are a breastfed baby. So that's something that we really stress in NICU, and if you know, for any time that we are helping care for a child that an infant, especially if they were a preemie, we stress to the mothers this benefit of breastfeeding or pumping if their child is at particular risk for not doing well if they were to contract RSV. The most severe symptoms occur in those less than 2 years old. Okay, you or I, if we got RSV, which you can get it over and over and over again, and if you work around kids, you will get it. What was I saying? So so if we get it, it's just going to cause a snotty nose. Sometimes it's worse than others. But the younger you are, the worse you handle it. Greater than 50% of us are affected by the time we're 1, and by the time we're 2, almost all of us have had RSV, our first case of RSV. But you get it over and over again. There is no permanent immunity, and reinfections are common. So here's the first of the common colds that we're talking about. That list of viruses on the respiratory viral panel that we test for, they can all be responsible for the otherwise known as common cold. I was explaining today, though, the reason we test in the hospital when we're very suspicious of a viral illness is because of the patients that we care for in a compromised setting. We don't, these germs are so contagious, we certainly don't want to spread RSV to a kid in the next room that we're taking care of with a congenital heart defect that is there for something totally innocuous and not even an infectious reason that they're admitted to the hospital. If they contracted something like RSV, they could have a very hard time with that. So we need to know what we're dealing with so that we know what precautions to put into place so that we know how to protect our other patients. Of the 90,000 annual hospitalizations due to RSV bronchiolitis, 80% of those patients are under a year of age. So this is our little kids that typically suffer from this. RSV is spread through contact. So these patients, we would always wear gloves and a gown with. Nosocomial infections are common. So there is a concern when we approach RSV season, whether or not we are going to be allowed gowns again on the pediatric floor. You know, on your adult floors, your main reason for wearing gowns may be MRSA or C. diff, but on peds, usually we're wearing gowns because of respiratory illness and the viruses that are spread through contact, RSV being one of the main ones. So some sources, depending on what source you're looking at, RSV has been proven to survive on skin and paper for an hour, and inanimate objects like surfaces for up to 6 hours. So if you lean against a crib, an infant crib that the child sneezed on or wiped their snotty face across their arm, and then their arm or hand touched the crib, and then you touched the crib and you didn't have your glove on, or you leaned against it and you didn't have a gown on, that virus can live on your clothes for up to 6 hours. So not having a gown on is a great way to spread the virus to your other patients. So just to repeat, the most common cause of bronchiolitis in children less than 2 is respiratory syncytial virus, and season is November to March. It usually peaks in January to February. So you can take all of that with a grain of salt. In the wintertime, it's RSV season, so get ready. So how do we test for RSV? So you can do a nasal swab or a washing, depending on what you have at your facility. We used to do the washing where you put some saline drops in the patient's nose, and then we suctioned those secretions out and collected them in a little specie trap and sent that washing to the lab. Now it's a simple test similar to a flu test where we just swab the nares, and you can test only for RSV, just like you can test only for flu, or you can send a viral respiratory panel and test for an array of different viral illnesses. It just depends on how it's ordered. So to recap, we're all infected at least once by the time we're 2 years of age. Reinfection throughout life is common. In older children and adults, it manifests just as your basic upper respiratory tract illness. It's just it makes you feel yucky. You've got the drainage, you've got maybe a little sore throat, may have a little cough going on, but serious disease can develop in elderly or asthmatic patients or immunocompromised people. Risk factors for severe disease with RSV: children less than 2 with chronic lung disease because they were premature, children less than 2 that have congenital heart disease, infants less than 1 that may not necessarily have chronic lung disease, but they were born early, before 32 weeks. They haven't made it to 2 years of age yet. They're less than 1, and they were, at least 8 weeks early or more. Infants born at 32 to 35 weeks, not terribly early, but definitely a little early, with either a child care attendance, or so they go to daycare, or they have a sibling less than 5, because kids that are around other kids bring RSV home. So some of you were in my clinical group when we got kicked out of the patient's room right off the bat that morning, because the mom was having a hard time with stress and anxiety because of guilt that she felt because her newborn had some type of illness, respiratory illness, and she felt like it was because she let her older child go to school that was like 4 or 5, and the kids brought the respiratory illness home to the baby. And she said she should have known better than to let her kids go to school with everything going on right now, and then they brought this home to her baby. So that is a very common way that illness is transmitted, and it's near impossible to prevent in all situations, but you just have to educate when you know you have a kid that's at high risk. You don't have friends over. You don't take the kid to Walmart. You don't take them to church. You keep them away from people where you're unnecessarily exposing them to illness. So early symptoms of RSV: your runny nose and congestion, a little bit of a cough, a little bit of a fever, and they're just not eating as well. So the kid's not going to tell you. Remember, we're talking less than 2. And a lot of times around 6 months of age was the average, okay? They can't tell you that they have a decreased appetite, but the parent will notice. And sometimes that's the first thing that the parents notice, is that they're just not eating their normal amounts. They may not have noticed that they're breathing faster than normal yet. They may not have really noticed any other symptoms, just that they're just not eating like they usually do. It's probably because they're starting to maybe have some inflammation in their nose, and it's just a little harder for them to breathe and eat at the same time. But as it progresses, the tachypnea can get very pronounced. These kids, when I first started, Vapotherm didn't exist. So when I first started, we would, by the time the child got to the PICU, they had been breathing 80, 90, 100 times a minute for who knows how long, and they would literally just exhaust themselves to a point where we're seeing spells of apnea, because they're just exhausted. Viruses take a long time to get better, and if it's causing tachypnea to that degree, they can't maintain. They don't have the strength to maintain that respiratory rate, and there's nothing we can do but let the illness run its course. So then we would, oftentimes the physician would elect to intubate the child and let them rest, give them some sedatives and let them sleep. And when they wake up, they'll be better. So, but of course, anytime you electively intubate a patient like that, there's a risk. So now we are blessed to have the high flow oxygen devices that we have, like Vapotherm, which we'll talk about, that is that stepping stone that is helping us. It prevents the need to intubate the children, and I'll explain how that works. So we have this severe tachypnea with different levels of distress. And you can see in this picture here, the sternal retractions, some subcostal retractions, and probably if we could see up closer, we also have probably some intercostal retractions there. And look at those eyes. There's not a whole lot of fight in that kid. They're just trying to breathe. They're just trying to stay alive, and they're not much interested in arguing with you or anything like that. You may see nasal flaring. You may hear grunting in this child because of the bronchiolitis that's going on. They may get to a point where they're trying to generate more PEEP by grunting, wheezing. Oftentimes, this is the first time that a child will wheeze is with RSV. That can be inspiratory and expiratory, or just expiratory, or varied throughout the course. If the child goes on to develop an RSV bronchiolitis / pneumonia, or an RSV pneumonia, it may get to the point where you're hearing crackles. The cough is common. They're just drowning in secretions, guys. They literally are blowing bubbles out of their nose with secretions. The bulb syringe is your friend, or the wall suction, whatever you're lucky enough to have. But we do a lot of educating with the parents to keep their noses sucked out. Eventually, they can get lethargic depending on how hypoxic they get. Anytime you have wheezing, you also have air trapping going on, because with expiratory wheezing, you can get air in. Anytime you wheeze, it tends to be expiratory, okay? You can get, and if you picture it like, picture the air's coming in, you can get it in, but because of the swelling and the inflammation, the air has a hard time getting out. That hard time getting out through those narrowed passages and all that mucus, that's when you hear your wheeze. That little bit of air that manages to squeeze out, the rest of the air gets trapped in the bronchioles. So you get air trapping. I'll go into air trapping a little bit more when we talk about asthma and other things that can cause air trapping. And again, we have a kid that doesn't want to eat because they've got all this going on. And of course, that will lead to dehydration. So other than easing their respiratory distress, we are also they're all drawings. I didn't. These kids end up dehydrated. We support them with respiratory stuff, and we support them with IV fluids. We do not feed a child with a respiratory rate greater than XYZ, whatever the doctor says. Sometimes they'll say hold feeds if respiratory rate greater than 60. NPO if respiratory rate greater than 60. Sometimes they may say 40. It depends on how old the child is. The parents, because the child is irritable, they want to stick a bottle in their mouth to ease them, to soothe them. And we really have to explain to them about how, depending on the age of the child, they don't know how to open, maybe they're obligate nasal breathers, but possibly until they're 6 months old, and they don't know how to open their mouth and breathe. And they can't breathe through their nose very well because they're all stopped up. If you stick a bottle in their mouth and they can't breathe through their nose, they don't know what to do. They can't breathe. So we really have to explain to the parents, no, we cannot feed them. Besides the risk for aspiration, it's going to make their respiratory distress worse. Because of this severe distress that the kids get into, it is not uncommon to have heart rates that exceed 140. They're just, tacking along because they're in so much distress. Plus you have that fever aspect and dehydration on top of the respiratory distress. But wheezy, crackly lungs, just remember, the wheezier the lungs, the better. If you've got to have a kid that's wheezing, you want to be able to hear the wheezing. When the wheezing goes away, it's either a really good thing because the child is obviously better. You can look at them and tell that they're improved, or it's a really bad thing because they still look bad, but the wheezing's gone. That means that those narrow passageways have completely occluded. The bronchioles have completely swollen shut, and there is no attempt at air. There is no air getting through. There is no movement of air. The attempt will still be there. I have seen a child look like they are breathing from the outside. Their chest was moving up and down in an attempt to move air, but it was almost reflexive. When you put a stethoscope on them, there was no air being moved. And we drew blood gas after blood gas that confirmed that the child was retaining more and more and more CO2. There was no air being moved, and they quickly required an intubation. So remember, as those bronchioles start to open up and respond to the bronchodilator, the wheezes will come back and they'll sound awful, like a washing machine, just really, really bad. But that at least you're hearing air movement, and we can work on that. We have room to improve, of course, but at least we have something to work with there. Because of all this air trapping, all this swelling that's going on in there, these children can quickly develop atelectasis, where portions of their lungs start to collapse. And they can also progress to a pneumonia. It can be strictly a viral pneumonia because of the RSV. It could start out as RSV pneumonia and then develop into a secondary bacterial pneumonia. Or they could just maintain at bronchiolitis. So RSV bronchiolitis does not equal RSV pneumonia, but RSV bronchiolitis can progress to RSV pneumonia. So how do we know when to admit these kids? Well, if you have a child that no matter what we do as far as breathing treatments, things like sucking their nose out, they still don't want to keep their SATs up, then of course that's concerning. If we have a child that is showing the retractions and signs of distress, the severe tachypnea along with retractions, they're dehydrated, or if not yet, obviously their oral intake history says that they are at risk for quickly becoming dehydrated. If the doctor just has a gut feeling that if I send this kid home, he might be okay, but this family lives an hour and a half away from the nearest emergency room, and honestly, the mom's really young, and I just don't know if they would get the baby back in time. I don't know that they have the, and it's a judgment. The doctor feels like he may not say it out loud, but he might be thinking, is this mom really going to set her clock and get up every hour and make sure her kid's nose is sucked out and that they're breathing? Because guys, RSV will kill the baby that was the miracle baby, that was the 23-weeker that survived in ICU with no brain bleeds, no gut surgeries, no cardiac defects. No, it was perfect, survived and was beautiful and perfect and has a great family and is home for 2 weeks, and they die from RSV. It's sickening, but it happens. So if the doctor has a gut feeling that, yeah, this kid probably doesn't need to be admitted, but dang, I'm just not going to take the chance. I don't want, I got to sleep at night. So he is totally within his or her right to admit the child just because they feel like they need to watch a little closer and they're not sure that they can, this kid's going to get the follow up they need. If the kid's less than 2 months of age, and if the infant has a history of prematurity, those are all added risk factors for them giving out a lot quicker than another kid would. So, keep in mind sometimes the first symptom of illness is apnea. So when we have these kids that have bruise at the house where they have a spell where they quit breathing, or the parent walks by and sees them have a color change and some inexplicable experience happens with the child that is scary for the parent, we will always do some basic blood work and a viral respiratory panel on these kids, because a lot of times that's just the first sign of a respiratory illness. These spells, apneic spells. So in the picture at the top, we have our, wait, let me get back up here. What is the spotlight? Shall we try it? Let's try it. Oh, we've done that. What's this one? Here, Amy nodding, look at that. Oh my goodness. Can y'all see that? That's crazy. Here we have subcostal retractions. Subcostal. It's tracing the outline of the rib cage. And here we have intercostal retractions. Intercostal retractions. Here we have nasal flaring, intercostal retractions, subcostal retractions, substernal retractions. And here's an example of nasal flaring. Just be sure, if you note nasal flaring on a patient who has no other signs of respiratory distress, but you're like, oh my goodness, that's obviously nasal flaring, be sure you ask the parent if this is unusual for the child to flare their nostrils or if they always breathe that way, because it may just be the way they breathe, and it may have nothing to do with respiratory distress. So it's just a clue, just part of the picture, not the whole picture. Okay. Contagiousness of RSV. So I used to struggle with this. If you look on the CDC website, it says that RSV is spread via droplet transmission, via breathing, coughing, or sneezing, but it's not placed under a droplet precaution in the hospital setting. Instead, it's contact. So why is that? So the evidence has proven that when RSV is spread, we can trace back the mode of transmission as being through contact with contaminated surfaces. That's not to say that if an infant with RSV or another human with RSV sneezed in your mouth, that you could not catch RSV. It's just saying that the most common way and the most likely way you're going to catch RSV is by touching the door handle that is contaminated with RSV on your way out of the room, and then rubbing your nose or putting your hand, rubbing your eyes, putting your hands in your mouth and not washing your hands. So what do? I've taken off my gloves and my gown and washed my hands. As I walk out the door, I open that door, we have hand sanitizer right there at the door, and I get a glob in my hands, shut the door, and spread it in my hands real good, because you have to be aware that if the parent's been coming and going, they're not wearing gloves, they probably got RSV spread all over that room. So the virus can survive several hours on the hands and surfaces, depending on what source you read. Environmental surfaces, we set up to 6 hours, 30 minutes to an hour or more on hands. Whenever that infectious material contacts the mucous membranes in the eyes, the mouth, or the nose, or possibly through inhalation of droplets generated by sneezing or coughing, that's how it's spread. So it's one thing to say you can get the flu if you've been around somebody that's been coughing, but it's another thing to say if you touch anything in the house that the person with the flu has touched over the last 6 hours, you're probably going to get the flu. I mean, it's a whole lot more contagious than some of the viruses, talking about RSV. So it's very important that we don't, that we are not the cause of a nosocomial spread of RSV in the hospital setting. So to treat RSV, it is primarily supportive with IV fluids, saline drops, and bulb suction. They're on the monitor always, these kids, and with tachypnea or any kind of respiratory distress are on the full cardiorespiratory monitor. We're maintaining fever control. Now, if you have a child on Resp that when they first came in, we didn't know exactly what was going on. Maybe it's a bacterial pneumonia, maybe it's a viral. Well, over the course of 24 to 48 hours, we got their lab results back. Everything's pointing to a viral illness, and their swab came back, sure enough, RSV. Yet they're still on Resp. Have in your mind the rationale for why they're still on an antibiotic when we know they're positive for RSV or rhinoenterovirus or whatever it is. Read your doctor's notes. Did they have red, inflamed tympanic membranes? All of that mucus and snot that's in their little head sets them up for bilateral otitis media. They could have a patch on x-ray that maybe started as a viral look, but the next day it's starting to become more localized to one lobe or one area, and it's questionable whether we might not have a secondary bacterial pneumonia going on. So it's not necessarily a bad thing to still have a kid in the hospital with a viral illness, still being covered with an antibiotic when they are high risk for that bacterial infection, a secondary bacterial infection. We do not give cough medicines or decongestants to children. We never advocate for that. As far as the albuterol treatments, honestly, you probably never question it because your kid's wheezing, but the literature just doesn't support that kids do any better when we put them on bronchodilators. Now, I'm talking about infants with RSV in particular. You're talking about very young infants that are wheezing, and we know the cause is RSV. The literature does not say it definitely benefits the baby to get routine albuterol in comparison to the side effects of albuterol. You've already got a very tachycardic child because of their illness, and then you go and put your albuterol on top of that, and it's going to exacerbate that. What we do know we can do are the saline drops with suction, the IV hydration, the humidified oxygen as needed. But your book will tell you that bronchodilators, steroids like Solumedrol, which a lot of our patients with wheezing and inflammatory respiratory processes going on will be on Solumedrol. But the book says bronchodilators, steroids, and epinephrine are not recommended. So that's talking about your vaponephrine. But again, it's a regional thing. It depends on what part of the country you work in and what the doctors believe in and routinely practice. No one's going to tell them not to do it. It's just, they can do whatever they want based on their experience, but it's just the literature there that truly supports it. 3% saline, nebulized 3% saline or hypertonic saline. How does hypertonic saline, how does that work? Giving a breathing treatment of hypertonic saline. So your book will also explain this. It talks about a 2014 study showing that breathing treatments with hypertonic saline may improve status and decrease the length of their hospital stay. And it was interesting to learn about this for me. I had seen a respiratory therapist administer hypertonic saline, but I never really understood it until I read this paragraph in your book. It explains that in the respiratory tract, salt's mechanism of action is multifaceted. So salt particles are smaller than most particles that are in the air, so they can be inhaled deeper. Okay, so we can inhale salt deeper into the airways. Once the salt is in there, then it does a couple of different things that are good. Number one, the salt acts as a mucolytic, and it helps break up those secretions. It allows the kid to be able to, with CPT and position changes, get those secretions up. It also decreases bronchial edema. We know how, just think of Epsom salt. So it's going to decrease edema, and it's an antimicrobial. Hello. So it's killing, any type of germs possibly that are trying to set up there. So due to these facts, and the facts that, it has this anti-inflammatory action, overall, it's just it's helping to suppress the hyperreactivity of the airways. It suppresses microbial growth. It suppresses edema, and it acts as the mucolytic. So it's a great thing that has like little to no side effects that you may see used. Do we see 3% saline ordered a lot in this capacity in the floor we're working on now at South? Honestly, I don't see it a whole lot, but some times of the year, depending on the doctor that's on, I do see it. So just be aware that that's out there, and that the literature supports that. And of course, you've got to work on keeping your airway open, head of bed up, make sure the child maintains the proper position. Because when you deal with these little kids, it's hard, these little babies, it's hard to keep them positioned in such a way that their airway's open and their head is tilted just so, with that blanket roll behind the occiput or the shoulders. It's a constant struggle. Just in case you were worried, humans are the only source of infection with RSV. You can't spread it to your cat, and you can't get it from your cat. So you can rest easy now. Direct or close contact with secretions. So that means secretions on the bed or the side rails or whatever. Large particle droplets less than 3 feet. So that means as far as droplet spread, you would need to be within 3 feet of the patient without a mask on to contract it via droplet spread. It may persist on surfaces. We've talked about that for hours, 30 minutes to an hour on hands. They're going to shed this virus for a long time. So as long as they're wheezing, they're contagious. As long as they're running fever, as long as they're snotty, just assume these kids are contagious up to 8 days or longer. After you've been around it, you can get sick as early as 2 days, or as late as a week later, you could start showing symptoms. So I tell you what, in an hour, I'm going to stop this recording here with Synagis, and we're wrapping up RSV, and we're going to talk about this vaccine called Synagis when we start the next recording, which I'll work on tomorrow after clinical, and we'll try to get it this lesson wrapped up with tomorrow's recording. So I think an hour at a time is about as much as anybody can take, and we'll go from there. So we'll see you tomorrow.